Was waiting for Pratik, and Pratik is here. Right. Right, let's start. Okay. So, hi everyone. Welcome to part two of this enjoying webinar. We just continue what we started a month ago about glucose disorders and rare syndromes and neonatal diabetes mellitus. It was very fascinating talk that our main speaker, Dr. Pratik Shah, had given, and he opened eyes for lots of things. And it seems to be enjoyed session. The recorded session was distributed among the attendees, and discussions continued since then. So we're here today meeting to go with part two, which is going to be case-based discussion this time, where we got three presenters, junior pediatric endocrinologists, who are going to present their cases shortly, each one to present his case or her case within hopefully 7 minutes. And then Dr. Shah will give his comments about these talks, and then he will take us to his experience and will show some of his cases. Okay, and now today we have an exceptional, and I'm very delighted to introduce Ms. Sarah Dearman from UK, who nicely joined us to share with us the amazing work that they do within the hyperinsulinism, the Children's Hyperinsulinism Charity, which is a UK-based charity. Ms. Dearman is the chair and trustee of this charity, and they are doing really amazing work. I was astonished by what they are doing by visiting the website. So I thought it's really a good opportunity to see what they are doing and to share with you guys. And we need to learn from their experience and the things that they do in the UK, for example, and then perhaps we export these ideas to different countries and different regions in the world. Let's be advocate for patients wherever they are, and we need to listen to Miss Sarah. So I think I will open this speech. I will talk our webinar by having Sarah to enlighten us within 10 minutes about what they are doing, and then we'll go to the Dr. Shah to lay out the structure of the meeting afterwards, just basic Q&As, and then the presenters, and then back to Dr. Shah. Okay, so Sarah, floor is yours.
Okay. Sorry, just shall I share the screen? Sorry.
Yeah, please go ahead. And then you just put it on the presentation mode.
Is that okay?
Yeah, fantastic.
Brilliant. Thank you very much. Hello, and thank you for inviting me to speak today. I'm here to tell you a little bit about the Children's Hyperinsulinism Charity. We are a volunteer-run charity, and we're led by hyperinsulinism parents. We support families across the UK and Ireland, and we work closely with the HI specialist teams, and we are honoured to have Dr. Pratik Shah as our patron. On Saturday, the 7th of June, we will be celebrating Hyperinsulinism Awareness Day, and this year our theme is Support that Shapes the Future. By listening to families, we can shape a strategy for hyperinsulinism that truly meets their needs and makes a real difference to their lives. Our charity began with a support group. That support group has always been at the heart of what we do, and it is a welcoming space where families can come together, share experiences, and never feel alone. It quickly became more than just a group, it has become a community. We knew families needed more than online support, so we started bringing people together with our fun days, where HI children, young adults, and their siblings can meet others with HI, just like them. It's been incredible to watch the friendships develop and the strength of connection that has come with that. We also realised that families needed information that is clear, reliable, and up to date. So we created our family conferences where everyone is involved, from the parents to the children and young adults. They set the agenda, they ask questions, they take part in the discussions, and of course, there's plenty of fun and entertainment too. Families also started telling us what challenges they faced every day, and that helped to start tailoring our resources. One of the biggest concerns they faced was support at school, so we developed a teacher training day and a detailed school pack. This enabled the school to prepare for the pupil with hyperinsulinism and ensure that their medical needs were met. We also created newly diagnosed packs to reach families at this really key time when they feel most vulnerable, so they can access our support at the earliest opportunity. Currently, we are developing resources to help children and young adults build self-advocacy skills. These will be tailored for different age ranges, and they are all created for the children, young adults and families using webinars and feedback. We also recognised a real need for support with mental health and well-being, from babies to young adults and for parents too. As you will see from this slide, there is lots of identifying of differing needs, and by identifying these needs, we are now tailoring support and working with psychologists to help improve their lives. By listening to families and obtaining their feedback in our support group, we have now turned to patient-led research, and we're proud to be working with Great Ormond Street Hospital on a developmental research project and with CamRare on a neurological research project. As you can see from this slide, the research is all designed to answer family questions, and we will be involving them throughout, so we can meet their aims for better understanding and provide the evidence they've asked for to secure support. Families also wanted us to be their voice, so we began our advocacy campaign, including our ongoing UK Parliament project. One of our goals has been access to continuous glucose monitors for all families. CGMs are not right for everyone, but for many families, as you will see from the slides, they've made a huge difference to their quality of life, with things listed such as able to manage blood glucose independently, less missed school days, improved sleep quality, and a reduction in anxiety. We are proud to have also been involved in developing the UK national guidelines on hyperinsulinism. We ensured that family perspectives were included. We have also helped to produce patient information to the Institute of Health Visitors and recently to Genomics England as they start the Generation study, which is bringing newborn screening for hyperinsulinism into focus. We're always keen to work alongside clinicians and researchers, sharing family insights to help improve outcomes together. Collaboration is key for us, and we're so grateful for professionals who listen, involve, and value patient voice. And finally, families asked us for more awareness, so we have created the Hyperinsulinism Awareness Day. It is a chance to come together and share aims. One of our main aims is to help the public and professionals recognise the signs and symptoms of hypoglycemia in babies. As we know, early detection and intervention can be life-saving and minimise the risk of neurological harm. But sadly, as this slide shows, when families are not listened to and when concerns are dismissed, the consequences can be devastating. And this is why awareness and listening to families is so vital. We would love you to join us for Awareness Day. We would love you to share your aims, help raise awareness, and stand alongside our families. I'm really thankful for this opportunity to speak today, and I hope that I have showed you how we can make sure that support truly does shape the future. Thank you.
Thank you very much, Sarah. That's wonderful and amazing. So, in our part, we start taking the same slogan and the pattern and design for this year's celebration of congenital hyperinsulinism. We translated that already to Arabic, to Urdu, and Georgian, and I think there was another language. So we are preparing for the 7th of June, and we're going to celebrate the event with you guys. A fantastic idea. And I hope that we will have some sort of collaboration to support families in this part of the world. So thank you very much for being with us, and thank you very much for your nice presentation.
Thank you
That's
very
lovely.
much, and thanks for joining in. Thank you.
Amazing, amazing. Um, uh, Pratik, would you like to set up how's the presentation gonna be
Yeah, I don't mind.
on?
If you want, can you hear me?
Yes, yes,
Yeah, I don't mind. I can set up the scene and then we can do the cases.
yes.
Um, or we could do half and half. So I think some of the cases might be useful. So I just wanted to make sure whoever is around, we've got some like poll questions, and I've used Slido in my presentation. So I'm just going to put a message. Please, can you download Slido app? Um,
Not necessarily. They
oh,
can
is
do it
it not necessary? Okay, fine, fine.
from the web.
Okay, fine. Then it should be fine. Let me just share my presentation and then can you see this?
Nothing is coming up yet.
It's not coming up.
Yeah,
Okay.
something is, yeah, we see your slides now.
Is it better now? So I'm just going to make it bigger.
Are you planning to put on presentation mode?
Yeah.
Hello, hello, Dr. Sen.
Hi, Norlane.
Dr. Sen, there was a problem going on here with the net. Maybe Dr. Siddharth cannot join. Can I present his case? And secondly, my microphone was also not working. I don't know, unfortunately, what's happening here. Can you listen to me now?
I could hear you. I think we will sort out Dr. Sajjad's uh, connection issue. Uh, I'll be texting him. So if you bear with us, Dr. Pratik Shah is going to set up the scene, and then we're going to take your presentations afterwards.
So are you good for me to start?
Yeah, please go ahead.
Okay. So
All right,
thank
all
you,
right.
everyone. So I'm just going to quickly go through some questions. I just want to try and kind of set up the scene as basic thing. And I think especially with Sarah's talk, and I've got few questions on congenital hyperinsulinism being as a, because we've got a CHI day coming up on 7th of June. And I think that's really important for us, all of us, to join hands together. So what I've done is I've got some questions in multiple choice questions, and I don't want to take too much of time, but if you can try and answer, it's anonymous, so don't worry. We are not going to kind of look into that, but it's just something that I would like to know what's your understanding. So how would you define hypoglycemia in a neonate who is 48 hours of age? So you got this five options. Okay, I've put in millimoles per liter as well as in milligrams per deciliter. So what, according to you, is hypoglycemia in a neonate at 48 hours of age? So what blood glucose cutoff would you take? So if you can download, so if you can join the slider at this barcode, I've just scanned this QR code, and then you enter this number. And then if you can try and answer, that will be helpful. And then obviously we can discuss this um, at the end. I'm going to give about 15-20 seconds. Okay, so we've got, I think, 55% saying less than 2.6 and 45% saying less than 3. I'll come to that answer in a minute. So you've got a term baby who is 39 plus 5 weeks, normal delivery. Birth weight was 2.3 kilos. So the birth weight SDS was minus 2.5, so small for gestational age. Primary gravida mum, no other significant history. Had a normal examination after birth. On baby check on 21st 24 hours of life was noted on the postnatal ward was noted to have blood glucose of 38 milligrams per deciliter or 2.1 millimoles per liter. What is your next step? So either you take no action, feed and discharge, undertake hypoglycemia screen and treat hypoglycemia, and feed and monitor. Would you like to take a guess? I haven't got any answers yet. I'm not sure whether this poll is working.
Perhaps you need to reveal the answers from you.
Yeah, no. I'm going to go to the answers, but I just wanted to see if anybody can, do the poll. So if you can just choose an option, I'll reveal the answers now of first and second question together. Okay, I think just with the because of the time constraint, I'm just going to mention. So basically, when you have a baby there is no obviously universal criteria as such for a newborn baby. However, in the UK, and there is a guidelines which has just come out from British Association of Perinatal Medicine, which obviously suggests if there's no risk factor, then you take the blood glucose cutoff as less than 2 or 36 milligrams per deciliter. However, if there are risk factors, then they have suggested to take even higher blood glucose into consideration, which is 3.5 or 63 milligrams per deciliter, like if you're suspecting hyperinsulinism. However, in our unit, in our tertiary neonatal unit, and in quite a few other tertiary neonatal units in the UK, take the cutoff as 2.6 millimoles per liter or 48 milligrams per deciliter. So um, the question being is in the first 48 to 72 hours of life, we obviously try and keep the cutoff and see because if it is transient hypoglycemia, it should get better. However, if they're persistently low, which is after 48 to 72 hours, we would then keep cutoff of at least 3 millimoles per liter or 54 milligrams per deciliter, and then you undertake hypoglycemia screen. And in this question too, so I've told you about 24 hours of life. So what we would need to make sure is you don't discharge them. Most important thing is you feed and monitor. If the baby has persistent hypoglycemia, i.e. the cutoff is less than 48 milligrams per deciliter or 2.6 millimoles per liter, then you undertake hypoglycemia screen, and have to then monitor more frequently and look for the causes. Also, one of the question was this baby was IUGR. So just something for you to think of, that if babies have a risk factor, then you keep a threshold of a higher glucose threshold to treat as soon as you do the hypo screen, because most likely they could have hyperinsulinism. Okay, yeah, we've got the answer, which is feed and monitor. So the third question is the concentration of insulin at the time of hypoglycemia screen determines the severity of hyperinsulinism. Is that true? Yes. Or is that false? No. So the answer is actually false. So the concentration of insulin at the time of hypoglycemia does not determine the severity of HI. So 64% have said yes. So very, very importantly is that it doesn't matter if the insulin concentration is just detectable or if it's high. It doesn't really determine the severity of hyperinsulinism. When would you undertake genetic testing for hyperinsulinism? So you would undertake testing for hyperinsulinism in all children with confirmed CHI, in children with transient form of hyperinsulinism, in children requiring high dose of diazoxide or unresponsive to diazoxide, or children with family history of diabetes. So this is a quiz. So we will gradually, we'll get the answer now shortly. So it's quite interesting. We would generally not do with all confirmed cases of hyperinsulinism. Obviously, those with transient forms or those requiring low dose of diazoxide, there is enough evidence that they are likely to be negative genetics. Obviously, if there is significant family history, then you could consider, but definitely you do genetic testing for children requiring high dose of diazoxide or unresponsive to diazoxide. And the high dose meaning is anyone above 5 to 7 milligrams per kilo per day. Okay, so we've got a 10-month-old boy who presented with hypoglycemic seizure with a blood glucose of 24 milligrams per deciliter, 1.4 millimoles per liter. The boy was well in himself. There's no history of illness. This was the first afebrile seizures, which was noted around midday. So he woke up at 7 a.m., had his milk. He had been very active and playing, and then he had food at 11 a.m. and parents reported that he had a mashed egg and fruit puree. This is the first time he had this egg. And this is actually a very similar case. So we had in A&E. So observations were stable, had normal blood, so they did full septic screen and had normal bloods. The hypoglycemia screen, which was undertaken, showed that there was detectable insulin and low fatty acids and low ketones, and lactate was normal, cortisol was normal, and ammonia was raised. So um, what do you think what genetic cause do you likely think is? So you've got a child who's had food at 11 o'clock, had then hypoglycemic seizure, confirmed hyperinsulinism, and has got slightly raised ammonia. So what genetic cause you think could it be? Okay, so yeah, so it's GLUT1, which is glutamate dehydrogenase 1 gene mutation, which is also called HIHA, hyperinsulinic hyperammonemic syndrome, in which you will have children are presenting typically after having protein-rich meal. So in this scenario, the child had egg, and subsequently after 1 hour of eating egg had hypoglycemic seizure, which was obviously protein induced. And also you will notice that they will have raised ammonia. Generally, they will respond to diazoxide, but it's very important to kind of get history, which is very typical that, they will have postprandial hypoglycemia, especially after having protein intake. When would you consider undertaking nuclear imaging in a child with hyperinsulinism? So those who are unresponsive to diazoxide, those with autosomal recessive KATP channel mutation, those with paternal inherited KATP channel mutation, or those with maternal inherited KATP channel mutation, or all of the above.
It says voting closed, Pratik.
Okay. So it's all of the, no, sorry, it's not all of the above, it's paternal KATP channel mutation. So mainly is when you think about when a child is not responding to diazoxide, you obviously send off, or if they're requiring high dose of diazoxide, then you send off the genetics. But if they have paternal inherited KATP channel mutation, then that's when you would do the imaging. Or if they are unresponsive to diazoxide but have negative genetics. So apologies, it's not all of the above, it's paternal KATP channel mutation. What is diazoxide responsive? How do you define diazoxide responsive hyperinsulinism in a neonate? So if you would kind of say on a maximum dose of diazoxide and feeding 3 to 4 hourly, on a minimum dose of diazoxide and feeding 3 to 4 hourly, on diazoxide but has occasional hypoglycemia, but generally stable on 4 hourly feeds, or on diazoxide and fast appropriately for age, or none of the above.
Again, the voting is closed. It doesn't allow us to vote.
It doesn't allow you to vote. Okay. Sorry, so I think I might have closed the voting. But it mainly is that it's on diazoxide who and appropriately fast for age. So most important thing is that all children who are diazoxide responsive, meaning if they're feeding 4 hourly or 5 hourly, but more importantly is to make sure they fast appropriately age, which in a neonate would generally be 6 hour fast. So they should be at least fasting for 6 hours or 6 to 7 hours before they go home. So what I'm going to do now is I think we've got a couple of cases, and then I've got this few cases which is sort of interesting, but I'm going to have a look at my quiz quickly. But otherwise we can start the cases, and then I can go. There are two cases which I have it, but I can do it at the end, and I'm happy to discuss those. So I'm just going to go to
Sir, can I present?
yeah, sorry, I'm just going to trying to find the screen. Yeah. Yeah, that's fine. Yeah. So I think we can now go on to cases. Who would like to go first?
Okay, sir. Can I present now?
Yeah, sure, sure.
Can you see my screen now?
Yes.
Okay, fine. So I'm not Nurulan Mehek. I'm a clinical fellow in pediatric endocrinology at the University of Child Health Sciences at the Children's Hospital, Lahore. I'm going to share a very interesting case of a girl who presented to us with dysglycemias and severe short stature. So this girl presented at the age of
No,
five
no,
and a half.
no, sorry to stop you. Can just put it on the presentation mode? Yeah.
Um, is this fine now?
No, it's not coming up yet.
Can't see. No.
Can't see.
Do you have any problem, Noor? Noor, do you hear me?
Yes, sir. I can hear you now.
Okay. If you just put that share slides like you did in the previously.
I think there is a connection error.
Okay. So shall we take another presenter
Uh,
while
yeah, sir. Please go ahead. I just
Dr. Amal, if
Yeah.
you're ready, please present your
Yes,
case.
thank you very much.
Dr. Amal, Dr. Noor, what's happening?
We have connection error, Doctor. I'm trying to share the slide.
Yeah,
Okay.
yeah, we can see that.
Yeah,
You
can
can
see.
see slides coming up, but you need to put it in the presentation mode. Yes, perfect. Go ahead.
Okay.
So Dr. Amal Leilani is a consultant pediatrician with a pediatric endocrine interest at Kirkuk in northern Iraq.
Thank you very much for this opportunity, Dr. Hussein. I'm going to introduce two of my cases, recent cases having hypoglycemia. First one is Yazan, who is a 28 months old male, presented with abnormal body movement for few minutes duration. Yazan had his fourth attack of loss of consciousness and convulsion. Actually, that happened after getting up in the morning. He lost his consciousness, then developed tonic-clonic seizure, came to the emergency unit with a random blood sugar 7. And after resuscitation, he gained his consciousness, and we kept him in the hospital to follow up and to find out the cause of the hypoglycemia. Next morning, his random blood sugar was 56, and we kept him to take the critical sample. When his random reached 33, we did take the critical sample for evaluation. On examination, he was doing well, no organomegaly and no abnormal finding. His critical sample showed that the C-peptide insulin level were nearly undetectable, but we sent urine for we sent also for urine sample as a critical sample. It showed presence of 3+ ketone bodies and positive reducing substance. He was seen by another colleague who sent for an expanded neonatal screening panel that showed the presence of immune reactive trypsinogen. Sweat test was negative. Then we sent for genetic tests that came back with a problem in a gene FBPI-P1, the fructose 1,6 biphosphatase deficiency. That means that a very rare condition, autosomal recessive condition, in which the child is going to develop hypoglycemic attacks, sometimes hyperventilation, apneic spells, seizure, even coma, after exposure to conditions like, for example, fever, stress, or even after consumption of large amount of fructose. This is the critical sample, and the evaluation of hypoglycemia is according either having acidemia or non-acidemia, and accordingly the management is done. The take-home message is that the urine for reducing substance is very important. It may carry the clue for the diagnosis. Case 2 was Jagard, who is 8 years old male, who presented with lethargy and vomiting for 3 days duration. Jagard was really tired when we received him in the emergency unit. He had high fever, he was acidotic, and he was very tired from the vomiting. Systemic review showed that he had diffuse abdominal pain, headache, attacks of headache, in addition to the muscle pain. Past medical history at age 3 years was admitted because of chest infection, and since age 5 years, he had recurrent attacks of hypoglycemia about twice every month. The developmental history had very poor school performance because of being absent many times because of the hypoglycemia. Consanguineous, he was a product of consanguineous marriage. There was a history of same condition in his cousin, as a decreased level of consciousness, attacks of hypoglycemia not diagnosed. On examination, he had hepatomegaly, 3 centimeter below costal margin. Neurological examination otherwise was normal. His parameter showed that his body weight was in the 10th centile, height in the 25th centile. We sent for the ABG that showed the presence of acidosis, metabolic acidosis, and his blood test showed the high serum triglyceride. He had also the present C-peptide and the insulin level were low, but the serum uric acid also was high. The CPK was high. After 2 weeks, we revised his condition that showed the CPK about 1,500, and still the triglyceride was high. The serum cholesterol also was high. We assumed this is a glycogen storage disease, and we sent for genetic test. We are waiting for the result. Take-home message that the glucose level should be measured every time the critical sample is collected in order to accurately interpret the insulin result. Thank you very much.
Thank you very much, Dr. Amal, for your cases, and thank you very much for keeping the presentation to the time. Pratik, would you like to discuss them now, or do you want to come back to
I
them
think
later?
I think we can discuss now, I guess,
Yeah,
isn't
I
it?
guess it's better. Yeah.
So thank you very much, Dr. Kamal. Would
Thank
you
you,
like
Dr.
would you like to go back to your first case on your presentation? I think those cases were really nicely presented, and I think, um, you had a very sort of good take-home message. Just wanted to ask you, did we do blood gas on this child?
For whom? For Yazan? Yes, there was acidosis, metabolic
There
acidosis.
was metabolic acidosis. And
And
I'm not sure whether you can measure fructose 1,6 bisphosphate in the blood. I'm not sure whether your lab have that facility, but obviously you've got these genetic results. And how have you managed this child?
we had admitted him to the hospital and he was given glucose. Actually, he was semi-conscious, or let's say he was conscious, but not very looking very well. So he was able to take an oral sugar fluid, let's say. But we put for him an IV cannula and managed him in the emergency unit by giving him 10% glucose. And, 5 cc per kg was given, and then he was doing very well. He had taken oral sugar and also received IV. IV.
And then at home, so what are you, sorry, I think, Nurulan, do you mind muting yourself? There's a lot of background noise. Thank you. So can I just ask, so when you discharged home, how are you managing it right now?
Uh, Actually, doctor, we kept him for next day. We didn't discharge him for further evaluation and for waiting for the critical sample. But what happened that they saw that the child is doing very well till the evening. So after they did the critical sample, they were absent. Actually, he was admitting to many times to the emergency unit and getting out. They used to have these attacks of hypoglycemia. Therefore, he was seen by the colleague, Dr. Bawai Shaswar Bawai, who sent for this. Let me show you that panel of neonatal screening expanded. Thought that this is cystic fibrosis. But then they returned back and we did the genetic test for him. We recommended that he should not consume a lot of amount of fruits, and with good education, that whenever he develop such attack of decreased consciousness level or disturbance in consciousness level, we should check his random blood sugar, and if it is not available, give him a sugary fluid, cola or juice, something. And then after that, not to have a lot of time asleep or fasting. If he sleep, for example, at 8 p.m., they should awake him in the midnight and give him, for example, a biscuit or some meal, so that to ensure that he will not have hypoglycemia. Whenever he is having an acute illness, they should follow his sugar level so that he will not develop hypoglycemia. This is a chronic condition and there is no cure from it, but to be followed later on.
Okay. So yeah, I think you mentioned very good points. So just something to highlight. Please avoid juices that has got fructose. So one most important thing is that you have to avoid fructose in this. So dietary management is really critical. So ensure that you do not give any food products or any juices that has got fructose. Um,
Yes.
as that's one. Secondly, is giving cornstarch. So you could consider giving corn flour at bedtime. So
Yes,
if this,
uncooked corn flour. Yes.
yeah, so you could consider giving at bedtime if you feel that this child has got, poor fasting tolerance, or if needed at the time of being unwell. You could consider, so there's a glucose polymer drinks. So you could consider giving only pure glucose drinks. So avoiding fructose, but you could give a pure glucose polymer drink when the child is unwell. So it's really, really important for to think about that if he does become unwell, you do not want to give juices that has got fructose, and that's going to precipitate high.
Cola could be.
Yeah. So
May I add a couple of points here as well? So some food containing sweeteners like sucrose or sorbitol, those can precipitate the condition as well, so make it worse. I think those are the sweeteners that can be avoided as well in such cases.
So it should be only pure glucose, correct? So just make sure that it's only pure glucose. So even I'm not sure about cola. I mean, generally the treatment for hypo would be glucose powder. So I'm not sure whether you can get glucose powder in your country, but it's just something for you to think of that. But that's really interesting case. Thank you for very much for sharing. And I think the second one which you mentioned.
Pratik, can we just before moving, for those patients, they have during the crisis, they will have lactic acidosis. So preferably, if they get managed with IV fluids, ringer lactate to be avoided in such cases because that make it worse.
Yes, so they will need IV fluids. So generally, sometimes they even need correction of their acidosis. So they will need IV fluids and sometimes correction of their acidosis when they're present in A&E. Thanks. And then the second case.
We
So
assume that the glycogen storage disease, doctor, because there was a high family history positive and there was a high triglyceride level, and the uric acid was high. The CPK also was high, and he had hepatomegaly.
and have you got ketones by any chance? Ketones and fatty acids?
3 plus ketones in the urine, but no reducing substance, negative reducing substance in urine.
So it's ketotic hypoglycemia, and possibly this could be glycogen storage disease. Obviously, if you can do glycogen storage panel, that would be useful.
We did, and we are waiting for the result.
Fair enough.
Dr. Amal, what was the glucose with this sample when you got this insulin results of 4.7 microgram per mil? What was the glucose on this?
It was low, actually 20, 25. We had a chart for his sugar level. Always it was low, doctor. He had that abdominal pain and vomiting, and they used to have these attacks. But unfortunately, they did not dig behind it because they said it is common in our family, and we had other members also had these conditions, but he had severe acidosis, so the glucose level was low, 20, 23,
If you just
30.
if you just go back a slide. So if the glucose was 20 with that insulin of 4.7 microgram per mil, so that's inappropriate insulin, isn't it?
Yes, it could be. Yes, I agree with you because it is detectable. It is normal level. It should be low, very low, like the CC peptide we see here. So it could be lab error.
And the ketones, you said that 3 plus ketones were there?
Yes, on follow-up, when he was doing very well on the uncooked cornstarch that he disliked very much, we recommended having the uncooked the cornstarch. The ketones was only 1 plus, but the serum triglyceride and the serum uric acid were still very high. The CPK also very high, 1,500. Therefore, the family convinced to do the panel for the glycogen storage disease. You know, it is somewhat expensive in our locality, but they convinced to do it. I'm waiting for the result. Once I receive it, I will update you, Dr. Hussein.
Okay, interesting. Thank you.
Yeah, you've also got detectable insulin, to be honest, at the time of hypoglycemia. Though obviously you give a range, but the fact that there is detectable insulin, I was just converting into our UK units, and it is actually detectable. So any detectable insulin at the time of hypoglycemia, you should think about, I mean, hyperinsulinism, but obviously there is. So sometimes you may have detectable insulin, but you said you've got 3 plus ketones. So if it is possible, it would be good to do point of care ketones if the child is having hypoglycemic episode. So it will be useful to know whether the ketones and fatty acids are high or low.
Okay. Thank you very much, Dr. Amal.
Thanks.
Thank you.
Okay, we got Dr. Sajjad Habibullah from Lahore. Just unmute yourself. Dr. Amal, if you stop sharing, please.
How should I do that? Okay. Yeah, okay. I'm going to stop share.
Thank you.
Yes, thank you.
Dr. Sajjad, if you share your slides, please.
Hussein, I guess Sajjad is struggling in hearing us. There might be a problem in his
Okay,
speaker.
go ahead, Sumaya, then. You present
So,
on his
are you
behalf.
guys happy? I can present on behalf of Sajjad and Noor because they are just struggling a bit in internet connection.
Go ahead.
So, let me share first.
Go ahead. Pratik,
Can
you
you
know,
share the
Sumaya,
screen?
you know Pratik.
Yeah. Hi, Pratik. How are you?
Good, thanks. How are you?
I'm good. So, can you see my screen now?
Yes.
Yeah.
So I'm just going to present on behalf of Nurulan. This whole effort is actually Nurulan. She just dropped me a message that if I can help in presenting this case. So this is a very interesting case, a girl with dysglycemia and short stature. So this wonderful girl presented to us in our hospital at the age of 5.5 months with concern of abdominal distension for last 2 months, few episodes of hypoglycemia for last 1 month, and difficulty in breathing for 4 days. It's stuck again. Okay. On examination, she had hepatomegaly and abdominal distension. She was found to have severe metabolic acidosis, hypoglycemia, and hypertriglyceridemia, along with high uric acid level, and provisional diagnosis of glycogen storage disease was made, and biopsy was done. This girl was initially remained on gastroenterology follow-up because all the features were consistent with the diagnosis of GST type 1. She was started on cornstarch supplementation with frequent feeding and sent home. She remained on gastro follow-up for a quite long time. However, the family themselves, they weaned off the cornstarch because the father noticed that the girl is having postprandial hyperglycemia very frequently, especially when they gave a lot of cornstarch. And they came to us at the age of 9.5 years to endocrine department with the concern that other than this initial concern of GSD, the girl is really short, and they have done a lot of investigations to figure out what is the reason for her short stature. We took a detailed history. The birth history was unremarkable. There was no antenatal and natal concern, and she was initially a bit failure to thrive, but after that she gained weight. She was a product of cousin marriages, and there was a one sibling death at 1 day of life, which is not related to to the kid ailment. On examination, she was really short. Her height and weight were below third centile, and she was having a multiple bony deformities in the form of epiphyseal widening, limb length discrepancy, and severe genovalgum. She's definitely having hepatomegaly of 4 centimeter below costal margin, and spleen was not palpable. This was her centile chart. You can see at the age of 10 years around, her height and weight were pretty below the third centile. The parents do have some chunk of investigation in their hand because they were really concerned about height, thyroid function tests, IGF-1, sodium and potassium, and creatinine. Almost all were normal except that the potassium was on the lower side. We did some investigation because our clinical features were suggestive of rickets, and the calcium was found to be normal. Serum phosphate was quite low, that is 2 milligram per deciliter. Alkaline phosphatase was mildly raised. Vitamin D level were quite elevated because she was taking a lot of vitamin D by the local doctors. Parathyroid hormone level was 66.2. ABGs was showing normal on and gap metabolic acidosis. Her urine complete has glucose urea, amino acid urea, and phosphate urea. TRP was 78%. Interestingly, urinary calcium to creatinine ratio was slightly raised, which is 0.42, and ultrasound shows nephrocalcinosis. And when we did a detailed skeletal survey assessment by our radiological team, they said it was favoring the diagnosis of rickets. So at this point, we were having a kid with suspected glycogen storage disease who was having a hypophosphatemic rickets along with a proximal renal tubular acidosis. Our differential diagnosis was that is this glycogen storage disease is because of some metabolic condition like tyrosinemia or GST type 1 or Fantini-Beaker syndrome. So we extended our workup further. We asked the family to monitor the blood glucose, fasting lipid profile, LFTs, RFTs, urinary succinyl acetone, ultrasound abdomen was sent. We did an MDT and genetics of the kid was sent. Her RFTs, liver function tests, lipid profile were normal. Interestingly, urinary succinyl acetone level were also normal, and genetics were still pending. So the tyrosinemia diagnosis were very less likely. For the GST type 1, she doesn't fit into the clinical prototype of GST type 1. So you were just thinking, is this a case of Fantini-Beaker syndrome? The genetic reports revealed within 2 months, and she was having a homozygous variant of uncertain significance in SLC2A2 gene, which confirmed the diagnosis of Fantini-Beaker syndrome. So the patient was started on polycitra K solution, 20 ml 8 hourly, along with Julie solution, along with a low dose of alpha D. And she started gaining a little bit of an height, but because she presented so late to us, her short stature is still a concern. If you look at the profile at the follow-up, her sodium and potassiums are normal, the calcium is normal, the phosphate is normal, alkaline phosphatase turned back to the normal values, but she still have slightly raised urinary calcium to creatinine ratio, which is actually one of the feature of Fantini-Beaker syndrome. So I feel the take-home message from this presentation is that even if you're suspecting a glycogen storage disease or a child with glucose dysregulation with a big liver, we always need to think of proximal RTA, and there are many glucose dysregulation defect which can present late as a very short stature, because this is a very late presentation of this condition, and because of that, the girl height was severely compromised. Thank you so much.
Thank you very much, Sumaya.
Thank you very much, Somaya. Very interesting case. Can I ask, did we have HbA1c, recent HbA1c?
So we had a recent HbA1c. It was 5.6. So she was not in on diabetic range. Her blood glucose profile was normal. Initially, the father was telling me that there was a concern of hypoglycemia and hyperglycemia, but the hyperglycemia is around 200 milligram per deciliter, not more than that. But interestingly, she doesn't have any diabetes.
So the hyperglycemia, but 200 milligrams per deciliter, which is 2 hours after meal, is that right?
Yeah, and he was telling me that is why he stopped cornstarch, because the gastro team was very keen to start cornstarch because of hypoglycemia, and then he noticed himself that, oh, when I give the cornstarch, the blood glucose spikes more. So he stopped the cornstarch at his own.
Okay.
When he came to us, the glucose dysregulation was not a concern by the family.
So the blood glucose postprandial is also normal.
Yeah, it's normal now. At this moment, it's normal.
Yeah, I think it's really interesting. So short stature is obviously one of the known presentation in this condition. The only thing is it will be useful just to intermittently check blood glucose, or either HbA1c, or parents can just do postprandial and fasting glucose at home intermittently, if because they can develop diabetes. And important thing is also to keep an eye on that. So obviously she's going through puberty, so that would be one of the things to think of.
Pratik, another interesting fact about this kid is initially we thought this high urine calcium to creatinine ratio is because of very high vitamin D level, because she was taking a lot of cholecalciferol by the local doctors. But this hypercalciuria is somehow a persistent feature because she's on our follow for last 4 years now, even being on normal calcium. Then we searched the literature and they feel the Fanconi-Becker syndrome do have association with the hypercalciuria. I tried to figure out what is the reason for that, but I don't know. Maybe Hussein or you, if you want to comment on that, or if you want to do something for that hypercalciuria or nothing, because you do have the nephrocalcinosis even on kidney.
So that's something. It's a known renal tubular defect. Though I mean the calcium is normal, isn't it? So calcium
Yeah,
is
it's
so unfortunately, I think obviously they can have nephrocalcinosis as long as the renal function is stable and we're keeping normal calcium levels, we're monitoring it and it's normal calcium. I'm not sure whether you can actually really treat hypercalciuria.
Don't think so.
Thank you.
Thank you very much. So from your side, Sumaya, do we have more presentation? You presented on behalf of Noor
Nurulan.
Naeem. What about
Sajjad, let me, so can you see my slides now?
we see
Yes.
your slides? You're going to present on his behalf as well?
Yeah, I'm just gonna move. Okay, so this case I'm presenting on behalf of Dr. Sajjad Habibullah,
Can you
who is
listen
one of,
me?
hello? Sajjad, can you hear me?
Yes, I can hear you from
So
mobile.
what we can do, you can do presentation and I can change the slides. What do you think? If you're struggling in
Oh,
putting presentation,
yes, ma'am.
that's
It's
great.
okay.
So go ahead.
Teamwork.
So I am Dr. Sajjad. I am working as a fellow pediatric endocrinology Children's Hospital Lahore under the supervision of Dr. Sumaya Aftab. I am going to present a case with persistent hyperglycemia. 5-month-old male child was presented to us in endocrine department with a history of polyuria, polydipsia, and failure to thrive from 1 month. Also, he was having respiratory difficulty from 2 days. Further history, he was full-term C-section born, having normal birth weight. The mother was having no any illness during the pregnancy, and the perinatal history was insignificant. He was the product of consanguineous parents. They was having two healthy siblings. There was a history of one sibling death at the age of 1.5 years. He was diagnosed as a case of neonatal diabetes mellitus at the age of 3 months. So next slide.
Sorry. Yes.
He was the past history and the drug history and the developmental history was unremarkable. He was having no syndromic facies. His weight was 5 kg and length was 62 centimeter at the time of presentation. He was irritable with acidotic breathing and having the vitals of temperature of 98.6 Fahrenheit. Respiratory rate was 62 per minute and the pulse was 115 per minute and the blood pressure was 70 by 50 millimeter of mercury. He was dehydrated, having normal vesicular breathing, and rest of the systemic examination was unremarkable. On investigations, he was having persistent hyperglycemia and with acidosis, pH was 7.01 and the BICA was 4.5. Other investigations were, the significant investigations were blood ketones, which were 7.2 millimole of liter, and HbA1c was 11.2%, and the C-peptide was 0.06 nanomole per liter. So HbA1c was high. Based on the history and the investigations, we label the case as neonatal diabetes with diabetic ketoacidosis. So the patient was managed in our department, admitted, and started decay protocol. When the patient was stabilized and out of decay, we started insulin glargine 1 unit BD with correction with the regular insulin 6 hourly, and the patient was taking breastfeed. On follow-up, at the age of 18 months, the patient presented with acute liver failure. He was admitted again, and insulin sliding scale was started, and he was treated conservatively. At the age of 4 years, he was again presented with liver failure, and he was managed conservatively. All the viral and autoimmune workup was done, which came to be normal. So he lost follow-up again and presented at the age of 6 years with the concerns of difficulty in walking and faltering growth, with the height of 96 centimeter, which was less than 3 standard deviations, and the weight was 13 kg, which was also less than third standard deviation. So he also developed distinct facial features having frontal bossing, broad joints, and kyphosis. His bone profile was done, which came to be normal. After we get the skeletal survey, there was epiphyseal dysplasia. So, based on the history examination and skeletal survey, the patient was neonatal diabetes with repeated liver failure and skeletal dysplasia. We suggested the potential diagnosis of Walcott-Rallison syndrome. So the whole exome sequencing was sent, and we found novel homozygous pathogenic mutation in EIF2 AK3 gene. So our diagnosis was confirmed, which was autosomal recessive Walcott-Rallison syndrome. Now, the current status is that the patient is 8 years old, having height and weight less than third centile, with BMI of 16.9 kg per meter square, and patient is on basal bolus. Our departmental data is we have 6 patients from the last 2 years, and unfortunately, 4 of them died with fulminant hepatic failure. So, what is Walcott-Rallison syndrome? It is an autosomal recessive syndrome which presented with the permanent neonatal diabetes mellitus, and the patients have a mutation in EI2AK3, which is eukaryotic translation initiation factor, which is required for the protein proper functioning of the protein. In the mutation, the protein is misfolded, which accumulates in the endoplasmic reticulum, and in the stress response, the cells undergo apoptosis. So in this syndrome, the patients present with early onset diabetes mellitus with spondyloepiphyseal dysplasia and recurrent hepatic and renal dysfunction. Although the pancreatic development is normal, but the misfolded or proteins accumulate in the pancreatic cells, which lead to the apoptosis of the cells, which cause the diabetes mellitus. So the patient with the permanent neonatal diabetes mellitus with the history of consanguineous parents and from highly inbred population, this syndrome should be considered. The fulminant hepatic failure is the main cause of the death in these patients, and there is no remedy for that up until now. We manage patients conservatively. The liver transplantation can be life-saving, which can improve the outcome in the individuals with this syndrome. So, thank you.
Thank you very much, Dr. Sajjad. Very interesting. Thank you.
Thank you very much. Yeah, it was really interesting. I guess this is something that which is the standard guidelines, is that all children with neonatal diabetes should have, their genetic screening. Obviously, we've had this typical phenotypic features, but one of the take-home message should be is that any child with neonatal diabetes should have genetic testing done.
Absolutely.
Sure, sir.
Thank you. Do we have any other cases?
I think no. We're done with the cases, so back to you.
I can quickly share. I mean, there's one interesting case I wanted to share. I think this is a case which I think Nurlan had presented, or Somaya's team had presented, but I don't want to give out the answer. Just give me 1 second.
Okay.
Okay, so I think the poll should work now, but I'm just going to kind of give you this thing. So a 2.8-year-old, and this we published as well. So 2.8-year-old referred to specialist center for evaluation due to acanthosis and episodes of postprandial and fasting hypoglycemia, and she had symptoms of hypoglycemia. So normal term child, term baby, not born to non-consanguineous parents, Afro-Caribbean in origin, and the birth weight. So she was born IUGR. There was no significant family history. There was initial report of neonatal hyperglycemia, but then that resolved at 3 weeks of age, so no further testing was undertaken. And at 2.8 years of age, she was then referred for unexplained episodes of hypoglycemia, especially when she was symptomatic in terms of being tired and lethargic. So on examination, her growth was satisfactory, weight was satisfactory, her BMI was normal, but she was noted to have acanthosis with slightly less adipose tissue. So when we did the test, so we considered doing further investigation. We did a fasting test, and she fasted for 12 hours, but noted to have hypoglycemia at the end of 12 hours. So we generally take the cutoff as 53 milligrams per deciliter or less than 3 millimoles per liter. And then we did a hypo screen as soon as it dropped below 3 millimoles per liter or 53 milligrams per deciliter. And then insulin was detectable with low fatty acids and ketones, so suggestive of hyperinsulinism. Then we also did oral glucose tolerance test, which showed that there was a postprandial hypoglycemia. So you can clearly see that at 3 hours, 2.5 hours, the blood glucose had dropped down to 1.6 millimoles per liter, which is about 30 milligrams per deciliter. And also at the same time, you can see the insulin levels, which were pretty high all the time. So they were significantly high during the oral glucose tolerance test. And then they also had other pituitary and metabolic workup, which was completely normal. So what do you think is a likely genetic cause? I hope it's working now. Is it working, or I'm not sure if the quiz is
It's warming up for me.
okay.
As enter your name, but it says voting closed.
Okay, voting closed. I'm not sure why. Okay, you could put answer in the chat group, but basically, the answer is insulin receptor mutation. Now, very typically is that children with this condition, you will see that they will have significant acanthosis, but the BMI will be normal. And you will have episodes of generally they will have episodes or they will develop diabetes, but occasionally some children do have fasting hypoglycemia. So how do we kind of manage this? So mainly is dietary management. So we obviously send this for genetic testing. Initially, it came back as negative, and then we undertook whole exome sequencing, and then we found there was a novel heterozygous mutation in insulin receptor gene. So mainly is dietary management. And initially we managed with Ecobos, which is sort of a glucosidase inhibitor, which sort of prevents postprandial hypoglycemia. Also had some cornstarch to prevent fasting hypoglycemia. So had cornstarch at bedtime. And then now obviously the child is much older, so we has developed diabetes. So currently is on metformin now. So I just wanted to share this, and I think one of the things would be useful is to have a hypo plan for children. So if you've got children with CHI or hyperinsulinism, make sure you've got a hypo plan that you will give to parents at home. This is similar that we have in our hospital. And if it's a non-CHI, so if it's a ketotic hypoglycemia, our cutoff is 54 milligrams per deciliter, or less than 3 millimoles per liter. So again, whatever your local guidelines are, you should try and make sure that parents have a clear hypo plan. So we also give SOS solutions. So we generally kind of say give SOS. SOS is just like Maxijoule or a glucose solution. So it's a pure glucose solution, which will obviously help to manage when they are unwell. And just as what Sarah mentioned about Hyperinsulinism Awareness Day, I just wanted to kind of, I don't know if there's any other questions. I think in terms of, I think we've pretty much gone through the cases. Any other questions?
Right. Thank you very much, Pratik. Let's see, and the Q&A. Well, lots of people are thanking you and thanking the presenters for the interesting cases. I'm not going to mention the names, but all of them, they're saying that we've learned from those cases. The questions, no, there were no questions. Those people were answering the previously asked questions, and Mona Sharaf is saying other factor in Fanconi pickle that then have delayed puberty with delayed born age and normal growth hormone. That's a comment rather than a question. Not really. No questions. Sumaya has got a question. Go on, Sumaya.
Pratik, can I ask you something? What is the earliest age to start cornstarch in children with hyperinsulinism? Because we normally used to start very early in our part of the world, but I understand that when I was working with you guys, you're always like, hey, do not start cornstarch so early. So what do you think? What is the rationale behind it, and what is the earliest age to consider that?
So there are centers who use under 2 years. So generally recommendations are over 2 years of age. However, in children with glycogen storage disease, metabolic team prefers to start glycoside, which is it's not cornstarch, but it's glycoside, which is a complex carb, which actually helps. So that could be started under 2 years of age. Now, if you don't have anything available, then there is people have also tried cornstarch under 2 years of age. We just have to let parents know about side effects like bloating and constipation. But we would then start on a very small dose if it helps.
Thank you.
Any questions?
And another question for GLUT1 mutation, the HEHA, what is the exact recommendation? That is avoiding pure protein diet, or some center recommend that reduce the amount of protein in your total intake. So what do you suggest, and what is the best way to manage it?
So it's a very good question. I think so. Mainly is we cannot really stop protein completely because it's obviously needed for growth. So it's very important that we tell parents to give small amount of protein, small portions of protein. But generally, how it works is they do carbs, then bit of protein, and then carbs again. So the meal should have carbs, protein, and carbs. So trying to avoid just protein rich meal, or trying to avoid only protein meal is not recommended, but just give carbs, protein, and carbs.
Thank you. Question
Thank you,
from Mona
Pratik.
Sharaf. Mona is asking, saying, thank you a lot. Regarding metformin in patients with NSR mutation, is there any rule of starting that before developing diabetes, starting metformin before developing diabetes, especially when they have severe acanthosis nigricans?
So not really. So obviously, in some children, so you monitor blood glucose. So if there is postprandial hyperglycemia, so generally children will present with, most of the children will not have fasting hypoglycemia, and their HbA1cs can still be normal, but can have postprandial hyperglycemia, which is on certain meals. Then yes, you can start metformin. What we would recommend is, yes, start metformin if there is evidence of postprandial hyperglycemia with normal HbA1c. But if you've got completely normal HbA1c and completely normal blood glucose levels, then you just monitor them, because you could have very mild form of insulin receptor mutation and they may not develop diabetes when they present to you. However, important thing is to keep monitoring them because they can develop diabetes or I would say impaired glucose tolerance. So if there's any evidence of impaired glucose tolerance, then yes, you should start metformin.
Fantastic. I think there's if people got access to continuous glucose monitor for such cases would be helpful perhaps to detect these kind of variation in their glucose.
Yes.
Nice. We've got a question. Is there any role for growth hormone treatment for patients with Fanconi-Bickel syndrome?
Not really. So it's short stature is a well-recognized feature of Fanconi-Bickel. And obviously, we would not really consider giving growth hormone uh, unless if they are growth hormone deficient or they are SGA.
Yeah. Nida Aslam is saying in Pakistan we are using Fantomalt along with Sando to prevent hypoglycemia in hyperinsulinism. Is it possible that we can add simple sugar to increase the meet of GIR requirement?
Yeah, I think the malt, what was it? That
The
is
Fantomalt.
Yeah, that is pure glucose. So yes, you could, I guess if it's a pure glucose, you could add in the feeds to increase the carbs. So we use Maxijule or Vitijule. I think that's similar. Then you can add to the feed to increase the glucose content in the feeds.
Sumaya is raising her
Yeah,
hand.
I just want to give a comment because in Pakistan we are struggling a lot. We don't have a Phantom Art is very expensive. So I had a discussion with Diva, the chai consultant in Chop actually. So they gave me a very interesting idea. They said, why don't you use icing sugar? Because icing sugar has a sugar and a little bit of the cornstarch, and it's very cheap. It's working very well for with our patients somehow. I know that this is not an ideal one, but just a way to help in those countries who are really struggling. Icing sugars do have a cornstarch and a simple sugar, and they somehow helps in maintaining the blood glucose.
That's really interesting. Correct. That's important. I think it's a learning point as well that we could use icing sugars. I think we just have to be careful about increasing the osmolality in the feeds. So
Yes.
we just have to be careful that we're not adding too much of carbs and increasing the osmolality of the feeds. But I think icing sugar is a really good alternative option.
Guys, are you aware of any guideline regarding the dietitian advice for patients with congenital hyperinsulinism? Like a take-home leaflets or booklets on diet and stuff.
So I think there is one published in the UK guidelines, which can be used. Generally, we just have to be mindful of increasing the carbs very slowly. So I'll give you a kind of a rough idea is a normal term formula has got about 7 grams per 100 ml, which is 7% glucose. We would step up slowly to 8%. So you add 1 gram of additional sugar. So 8%, 9%, 10%, generally up to about 10% is what we would do. But we just have to be mindful if they have diarrhea. The second option is using high calorie feeds. So the high calorie feeds that we have is about 9.5% of glucose, but it's carbs, so it's not sugar. So there are two ways. Either you have a normal feed and add sugar into it, which is just pure glucose, or you give high calorie feed. So most babies, like with IUGR or small for gestational age, they would get better with just high calorie feeds because then they will gain weight as well. And then in older children, you can even give more glucose content up to 12% of carbs. So it's very important to build up slowly and making sure that they don't develop any diarrhea or any abdominal side effects.
Thank you very much. Khanda is asking, Khanda Fishan Mumtaz is asking, are these patients with NSAR mutation at risk of PCOS?
Yes, so they are at a risk of they can have issues with puberty and they can have PCOS as well. But obviously we don't know exact reason, but their BMI is generally very normal. They just have severe acanthosis.
Okay. And Sajjad is raising his hand. Perhaps we will take him as a last question and then we will adjourn the meeting. Go on, Sajjad.
Yes, my question is from Sir Pratik Shah. Is there any role of growth hormone in managing the skeletal issues of the patients with Walcott-Allison syndrome?
Yeah, we generally would not recommend giving growth hormone if they have normal IGF-1 and no evidence of growth hormone deficiency.
Yeah.
Thank you, sir.
Thank you very much. Thank you so much, Pratik, for your participation in these sessions. The amount of messages, the thanking messages here, you can see yourself in the chat box from Khanda, from Rimsha, from Claudia, from Amina, from Phoebe, and all people just sending lots of thanks for these kind of discussions, which they found very, very useful in their day-to-day life and practice. So I do thank you sincerely for being with us in 2 sessions, and we hope to see you again. Farah is also sending her thanks, Sajjad. So a fond of thanks to you, and we hope to see you again.
Thank you very much for this, and I think it was really useful to interact and hear about the cases. So lovely presentations as well, the cases presentation. So thank you very much.
Appreciate it. Right. So on the 7th of June, we're going to share these kind of posts to support people with congenital hyperinsulinism. Yeah.
Thank
See
you.
you again. Bye-bye.
Thank you. Bye.